Hello, my name is Raul Clavijo. I am an attending urologist at the UC Davis Medical Center. My phone number is 916-734-2222, and you can also email me at the address listed here. Today we're going to talk about erectile dysfunction. First, we can start off by describing how common erectile dysfunction is. As you can see from this graph, it is clear from several studies that erectile dysfunction is quite rare, especially in patients when they're under 40 years of age. Unfortunately, once you hit 40 years of age and older, erectile problems start becoming a lot more common. Let's begin by reviewing a typical sexual encounter. It can be divided into four areas: arousal, erection, ejaculation, and detumescence. We'll focus on the first two by describing arousal and erection. The mechanism of arousal is very complex. There seem to be many parts of the brain that are activated during a sexual encounter, and several pathways through which an erection can be started. One important hormone mediating a lot of this seems to be testosterone. We will go more into detail later on regarding this topic. Let's quickly review the nervous system as it pertains to erections. There are a set of nerves that make up what is referred to as the parasympathetic nervous system. These are the nerves that bring in the signal from your spinal cord over to your penis. On the image here, the pelvic nerve, pelvic plexus, and cavernous nerve depict a simplified version of this part of the nervous system. The classic example of injury to this pathway is what a patient experiences after a prostate is removed for prostate cancer. During a prostate surgery, we try to spare the cavernous nerves that hug the prostate on each side. Even if we do spare most of the nerve fibers, there will always be injury due to several factors associated with surgery, including inflammation, stretching, and heat conduction. Thus, impairment of these nerves will prevent the proper transmission of signal from the spinal cord and into the penis. The sympathetic nervous system, on the other hand, drives ejaculation during sex and sends signals from the spine to the penis that leads to eradication of an erection after ejaculation. Problems with ejaculation usually arise with injury to these nerves. Another part of the nervous system that is important for erections is what is referred to as the motor neurons, or nerves that send signals from the spine to the muscles surrounding the base of the penis. From this image, one can see how tightening of these muscles can lead to maximal fullness of the penis. Zooming in, we can now focus on the inside of the penis at the cellular level. One can think of the inside of the penis as a sponge with small cavities that will only accept blood into it once the smooth muscle cells lining that sponge tissue relaxes. Here we see a cartoon of what a smooth muscle cell and all the molecular mechanisms by which one can achieve an erection. The primary pathway is the nitric oxide pathway. The cavernous nerve we previously mentioned uses nitric oxide and releases it to help relax the smooth muscle cells of the penis, allowing the penis to draw in more blood like a sponge. There are many medications that can affect these pathways that can lead to better erections. In fact, Viagra, otherwise known as sildenafil, works by preventing the degradation of a compound called cGMP, leading to a prolonged smooth muscle relaxation. Overall, the steps of an erection can be split up into a filling phase, where the smooth muscle relaxes, increasing cavernosal blood flow. A full erection, where the corporal bodies, or the cylinders that make up the penis, maximally engorge. The veins are occluded when this happens, allowing blood to stay inside the penis. And then you get a rigid erection, where the penis is maximally engorged via contraction of the bulbospongiosus and ischiocavernosus muscles we just described. Overall, an erection is a delicate balance of inflow and outflow of blood from the penis. A first step when evaluating a patient for erectile dysfunction is determining whether they have mostly a psychogenic or an organic or physical reason for their erectile dysfunction. As one can see in this table, psychogenic erectile dysfunction is characterized by a sudden onset of erectile dysfunction, a complete or immediate loss of erections. The morning erections are usually preserved, and the problems with erections can vary depending on partner and circumstance. On the other side, you have an organic or an anatomic reason why you have erectile dysfunction. It's typically gradual in onset, it's incremental in progression. Patients typically lack morning erections. and they typically are unable to get erections despite the sexual stimulation or circumstances. Although psychogenic erectile dysfunction is common in young men and can coexist in older men, it is more typical for older men to have a medical condition that affects their erections. Common problems that can lead to erectile dysfunction include neurologic problems like radical pelvic surgery, multiple sclerosis, stroke, spinal cord injury, and certain types of neuropathy. Vascular conditions that can affect patients are high blood pressure, diabetes, and tobacco use. Low testosterone and a condition called hyperprolactinemia can also contribute to this. And then medications like blood pressure medications, antidepressants, and certain hormonal agents can also affect erections. Anxiety, poor communication, and pornography addiction can also cause problems with erections. On a physical exam, things I typically look for are penile stretch length. I assess for penile plaques and penile lesions. And I also check for a condition called phimosis. It's where the foreskin cannot be pulled back fully. This can affect erections in some patients. I also look at the lower abdominal and pubic fat. This can determine what second-line treatments I can offer patients. Regarding blood work, there are no strict guidelines in terms of what a physician should order. I tend to check a testosterone as well as other labs that may be pertinent below. Fortunately, most patients come in with most of these labs having been checked already. The big question is to how much testosterone affects erections. Overall, it seems that replacing testosterone in men who are diagnosed with low testosterone can be of some benefit and bridge a small gap, but it rarely provides a large boost to erections, unfortunately. There are many options for testosterone replacement, which we will discuss in more detail in another presentation. Continuing on the evaluation of erectile dysfunction, I do recommend the penile duplex ultrasound on some patients. This study allows me to see how fast blood is flowing in and how fast blood is flowing out of the penis during an erection I induce with injectable medication. This test also allows me to evaluate a patient for curvature, scar tissue, and blood vessel abnormalities that patient can either be born with or that can be the result of an accident. Before starting a patient on erectile dysfunction treatment, we must first determine whether he can tolerate the stress on his heart by assessing exercise ability. I typically inquire as to whether a patient with a history of heart problems has been cleared by his cardiologist and whether he can easily go up 2 flights of stairs. Moving on, the treatment of erectile dysfunction, our first line is usually to determine if any medications may be contributing to erectile dysfunction. Of course, there are many medications, especially the very common ones in high blood pressure medications that contribute to erectile dysfunction. Unfortunately, by the time I see a patient in clinic, he has been on a certain medication for months to years, and changing the medication is unlikely to provide much benefit, and in fact may actually make his condition worse by worsening his high blood pressure. In this slide, we see a list of the 4 main oral medications that are currently available to use to treat erectile dysfunction. As one can see, we have a short-acting and a relatively quick-onset sildenafil, vardenafil, and avanafil, and a longer-acting tadalafil, otherwise known as Cialis. Most of these medications have similar side effects, with the most common one being headache. Now, if you research online, you may find several possible serious side effects of the medications just mentioned. One of the side effects is blindness. Now, there have been a few reported cases of patients starting a medication class called phosphodiesterase inhibitor, which includes things like Viagra and Cialis and the medications I just discussed. The condition that these patients develop is a condition called a non-arteritic anterior ischemic optic neuropathy. Now, it seems that at most this medication may increase your chances of this condition by 2 times. Now, this condition is already very rare, and increasing it by 2 times increases the overall absolute risk by a very small amount. Deafness has also been associated with these types of medications. This is sudden hearing loss that begins after starting a phosphodiesterase inhibitor. However, there is no established causation or incidence about how often this happens, and these cases are limited to what are called case reports. There has been one study that has associated melanoma with these types of erection medications, the phosphodiesterase inhibitors. However, no causation or no clear mechanism of action has been established, and at most, it just probably represents a very, very small risk. Hypotension is a real risk, and I do recommend patients taking nitrates or medications such as isosorbide mononitrate or dinitrate to not take phosphodiesterase inhibitors. Priapism is also a theoretical risk, and it's almost unheard of without the use of quote-unquote party drugs like cocaine, ecstasy, etc. The question now is, how should I take these medications? I usually begin by establishing how active a patient is. If the patient is having intercourse or wants an erection less than 2 times a week, I usually ask them to consider a Viagra or a Vanaphil as needed, since they're quick in onset and last in the bloodstream about 4 to 6 hours. If they want an erection more than 2 times a week, I usually ask them to consider a Cialis, a long-acting Cialis, or otherwise known as Tadalafil. They can either take this as a full dose of 20 milligrams or a small dose, 5 to 7 milligrams, daily or every other day. The added benefit is that this may also help urination in some patients with BPH or lower urinary tract symptoms. If a patient has poor renal function, meaning their kidneys are not working so well, I usually ask them to start with a low-dose Viagra, 25 milligrams. I would ask them to avoid Tadalafil and Vanaphil because one is long-acting and the other one hasn't been studied properly in these types of patients. The big issue with these medications tends to be the cost. I tend to get many messages regarding this issue, and you're right, insurance companies want to put as much of a barrier to you getting these medications as possible because they tend to be expensive. Luckily, the patents on sildenafil and tadalafil will run out soon and more generic options should be available. I do recommend against getting your products from unknown sources. By that I mean a non-pharmacy source, especially if it's from outside the United States. An option for some guys where the oral medications fail or don't quite work well enough is the vacuum erection device. Although this device can be cumbersome and take a lot of practice, I do have many patients who are able to use it efficiently and successfully. The addition of medications like tadalafil and sildenafil can help make it more likely that a patient uses a vacuum erection device successfully. This may be the only option in certain patients who cannot use any of the other treatments for erectile dysfunction. It is also useful in exercising the penis, quote unquote, after a prostate surgery, especially early on when one is not getting any blood flow to the penis at all. Moving on in terms of treatment options, let's discuss the medicated urethral suppository. Again, this is typically used in guys who have failed oral medications or need an extra boost. This medication involves placing a tiny gel-like pellet about the size of a small grain of rice into the urethra. Unfortunately, not many patients can use this successfully, and it can get quite expensive. Although I do have several patients who do successfully use this medication. Finally, in terms of medical or non-surgical options, we have penile injections. I do have a lot of patients cringe at the thought of injecting their penises, but most are surprised when they actually do it as to how easy and relatively pain-free it can be. Knowing that it is a tiny needle going in does help. Most are also able to achieve the best erection they've had in a long time with this medication. Although the medication does cost around $90 for about a 1.5 month supply, the teaching session and doctor visits for this are usually covered by insurance. This is important to realize as there are a lot of clinics out there that will charge you inflated prices for doctor visits and injection supplies. Overall, although penis injections are a good option for erectile dysfunction treatment, it is not without its disadvantages, which are listed here. Please note that there is a very small percentage of patients who can get penile scarring using injections, and therefore it is important for me to examine that patient or any patient on injections regularly to catch this early on. Finally, we have the surgical option, a penile implant. Interestingly, this surgical option was very well received among the patient population I saw during my fellowship in Miami. Here in Sacramento, there are many patients who state that they would not consider this option even if it was the only option that would restore capacity to have sexual relations again. I do have to say that, yes, surgery is a really scary thing to consider, especially in patients who have been through many other surgeries. However, from my experience in my own patients and from what is reported in the literature, the satisfaction rate tends to be quite high in patients who have this surgery. The other benefit is that Medicare does cover this surgery. A common misconception is that the penis implant or the penis pump is external in the body, and you have to quote unquote carry it somehow. In fact, as can be seen in these drawings here, the implant is completely inside the body. There are 2 cylinders inside the penis, a pump that goes in the scrotum that basically looks like a third testicle, and the reservoir, which is the balloon that holds the fluid that sits in the abdomen just above or next to your bladder. In terms of convenience and spontaneity, it's hard to beat the penile implant. To achieve an erection, one can use the pump located in the scrotum and squeeze it and to bring the fluid from the reservoir in the abdomen into the cylinders in the penis. It is quite dramatic how this can recreate a normal, firm erection suitable for penetration. With any surgery, there are risks and benefits. The risk being infection. About 1% of patients will get an infection. If you are a diabetic, unfortunately, you are at a slightly increased risk of infection. Malfunction is quite rare early on, and interestingly, 80% of these devices are working at 10 years after the surgery. There is also a risk of damaging the bladder, intestine, and major vessels. This is quite rare. The benefits of this of the penile implant are that it's easy to use and fast to use when you need it. The sensation of orgasm is not affected. And the cohort studies, meaning small group studies, show that patients tend to have a very high satisfaction rate. The other thing is that it may preserve your penis length. Imagine that if you go many years without a normal or good erection, you are likely to lose penis length. And therefore, in some patients, getting a penile implant early on may help preserve their penis length overall. Regarding upcoming or new treatments, there are currently 2 undergoing clinical studies. Shockwave therapy seems to be helpful in improving erections in a small or modest amount, meaning that those with mild erectile dysfunction will likely derive the most benefit. The best thing about it is that there are no significant side effects associated with shockwave treatment. However, until we know more about this treatment option, it should only be offered in a clinical investigation or a clinical trial setting. At least that is my opinion. Similarly, some studies have shown a small improvement at most with stem cell treatments for erectile dysfunction. As very little is known regarding long-term risks and there are no standard protocols for this, I would advise against this option outside of a clinical trial setting until we learn more. Again, my name is Raul Clavijo. I'm a urologist here at UC Davis in Sacramento, California. Thank you for listening. Here is my email address, and for appointments, please call 916-734-2222.